Assalamu alaikum. Welcome to my channel Pharmacology Made Easy. Today we'll discuss the second part or second session of hypertension. In this part, we'll discuss about some hypertensive comorbidities or hypertension with some comorbidities, and also about beta blockers. That first, we'll discuss about hypertension with comorbidities. What will be the management protocol, or what will be the treatment plan for this type of disease? In hypertension with bronchial asthma, we should give ARB or calcium channel blocker, and we should not be given the propanolol, the non-selective beta blockers, and ACE inhibitors. We should never be given these types of drug in hypertension with bronchial asthma or hypertension in COPD. So why we choose ARB, or why we choose calcium channel blockers in hypertension with bronchial asthma? These drugs will produce anti-hypertensive effect, and there will be no chance of bronchoconstriction over there. When we give the ARB, angiotensin receptor blockers, it not produce any bronchoconstrictor effect over the bronchus, or no, it control the pressure but not produce any bronchoconstriction. So in hypertension with the bronchial asthma, we can give these drugs easily. In case of calcium channel blockers, thus calcium channel blocker does not produce any bronchoconstriction over the bronchus. So we can give the calcium channel blockers in hypertension in bronchial asthma, but we should not give propanolol in case of bronchial hypertension with bronchial asthma. Why we should not give propanolol in hypertension with bronchial asthma? Propanolol is a non-selective beta blockers, so it means it blocks the beta 1 and beta 2 receptors. When it blocks the beta 1 receptors in heart, propanolol produce antihypertensive effect. We will discuss it later. But when it blocks the beta 2 receptors, and we know about the beta 2 receptors are present in the bronchial smooth muscle, in vascular smooth muscle, in genitourinary smooth muscle, and also in liver and the skeletal muscle. But what is the concerned thing in this? Propanolol acts on the beta 2 receptor of the bronchus and blocks it. So there will be bronchoconstriction, in where the myosin light chain becomes activated and myosin light chain become phosphorylated, and this myosin light chain phosphate uh, bind with the actin and produce the contraction of the bronchial smooth muscle. As far the propanolol blocks the beta 2 receptors, so where the beta 2 receptors produce relaxation, as far propanolol blocks the beta 2 receptors, it not causes relaxation, it produces contraction of the smooth muscle due to blocking of the beta 2 receptor on the smooth muscle of the bronchus, and causes bronchoconstriction. So in asthma, bronchial asthma, the patient feels bronchoconstriction, and there will be a dry cough, and there will be a shortness of breath and breathlessness. So when there over bronchoconstriction, in case of giving propanolol, the patient may die due to respiratory failure. So we should not give propanolol in case of hypertension with bronchial asthma or hypertension with COPD. We never ever should do this, and this is a professional crime by doing this. So okay, we have to remember that hypertension in bronchial asthma, we should never give the propanolol. The another drug we should not give in hypertension in bronchial asthma or hypertension in COPD, that is ACE inhibitor. The ACE inhibitors are ramipril, lisinopril, fosinipril, benzapril, captopril, enalapril. These are the drugs that comprises the ACE inhibitors. ACE means angiotensin converting enzyme. This angiotensin converting enzyme inhibitors not only inhibits the renin angiotensin aldosterone system, but also inhibits the bradykinin to becomes the bradykinin inactive metabolite in the lungs. So when bradykinin cannot be converted into inactive metabolites by ACE inhibitor, by angiotensin enzyme inhibitor drugs, normally the lungs bradykinin becomes inactive metabolite through angiotensin converting enzyme that is present in the lungs, but it can acts into the lungs and also in the renin angiotensin aldosterone system or in the kidney. So when it acts when the ACE angiotensin converting enzyme acts on the lungs, it inactivates the bradykinin into bradykinin inactive metabolites. But when we give angiotensin converting enzyme inhibitors, the bradykinin will not be breakdown, or bradykinin will not be converted into inactive metabolites. So increase the level of bradykinin, which causes much more production of prostaglandins, and the prostaglandins pathway, if we say, the prostacyclins are produced over there, and this prostacyclin may causes vasodilatation and decrease the blood pressure. But uh, by doing so, angiotensin converting enzyme inhibitors lowers blood pressure, but when they cannot inactivate the bradykinin level will be increased, and this bradykinin causes, and this increased level of bradykinin causes increased vascular permeability, produce bronchoconstriction, and produce dry, irritating, harassing cough. So when there is bronchial asthma, there will be bronchoconstriction and there will be cough. So these bradykinin that do not or inactivate into inactive metabolites, this increased level of bradykinin produce dry, irritating, harassing cough for this type of patient, and that will be increased chance of bronchoconstriction. So in hypertension with bronchial asthma, we'll never give anti angiotensin converting enzyme inhibitors. So these are the important comorbidities in treating hypertension with bronchial asthma. We treating the drug, and what are the drugs we cannot be given, that is discussed. Now hypertension with angina pectoris, we should give beta blockers and calcium channel blockers. Why we choose or why should we give beta blockers in angina pectoris? Because beta blockers, if we give the selective beta blockers which blocks the beta 1 receptor, it decrease the heart rate, decrease the force of contractility, decrease the cardiac output, and decrease the workload of the heart, and decrease the oxygen demand in the heart, and relief of anginal pain. So that's why we give the beta blockers in case of angina pectoris. You can also give calcium channel blockers over there. By giving calcium channel blockers, there will be vasodilatation and there will be more supply of oxygen to the heart, and there will be increase the perfusion of the heart, and this also relieve the angina pectoralis pain. So that's why these are the drugs we can give in hypertension with angina pectoris. Hypertension in diabetes mellitus or hypertension in diabetic nephropathy, we should choose AC inhibitors or ARB. But in case of bilateral renal artery stenosis, in case of diabetic patient or in case of diabetic nephropathic patient which have bilateral renal artery stenosis and which have hyperkalemia, we should not give AC inhibitors in this kind of patient. In diabetic nephropathy or in diabetes mellitus with hypertension, we can give the AC inhibitors, but in case of bilateral renal artery stenosis with CRF, with hyperkalemia, with hypertension, we should never give AC inhibitors. Okay. Why we should give AC inhibitors in hypertension with diabetes mellitus? AC inhibitors stabilize the proteinuria, and it inhibits the efferent glomerular arteriolar pressure, and ultimately it inhibits the glomerular pressure, and it reduces the glomerular pressure over the kidney. So that decrease the mortality of the patient, and that is improve the renal function. So we should give hypertension with diabetes mellitus, we should give the antihypertensive medication, that is ACE inhibitors. But in case of renal artery stenosis or in case of hyperkalemia in diabetes mellitus patient with hypertension, we should not give ACE inhibitors because it increases the pressure due to bilateral renal artery stenosis, increase the intraglomerular pressure, and makes it chance of more renal failure over there. And in case of hyperkalemia, ACE inhibitors, one of the adverse effect of ACE inhibitors is hyperkalemia. So in case of hyperkalemic patient, we should never give the ACE inhibitors because this hyperkalemia will becomes more potassium and more hyperkalemia develops in the blood, and more hyperkalemia may causes the paralysis of the ileus, or may causes heart attack, or may causes cardiac arrest in a few moments. So we should never give ACE inhibitors in hyperkalemic patient with diabetes mellitus with hypertension. So in this type of patient, bilateral renal artery stenosis in diabetes mellitus with hyperkalemia with hypertension, we should give ARB, angiotensin receptor blocker. Okay. In case of hypertension with heart block, we should never be given beta blockers over there because in heart block there will be bradycardia, and beta blockers produce more bradycardia. So beta blockers cannot be given. We should give the another drugs in case of this patient. In case of hypertension with heart failure, we should give ACE inhibitors, we should give ARB, we should give potassium sparing diuretics, spironolactone. These all are help in this all are in helps in inhibit the cardiac remodeling and makes the heart more stable to work. So these are the important comorbidities, hypertensive comorbidities, and how we treat it is discussed. Now beta blockers. Beta blockers, according to their selectivity, beta blockers are classified into selective beta blockers and non-selective beta blockers. Non-selective beta blockers are those beta blockers which not only inhibit the beta 1 receptor of the heart and kidney, it also inhibits the beta 2 receptor which is present over the bronchus, over the vascular smooth muscle, over the genitourinary smooth muscle, and also liver and skeletal muscle. So non-selective beta blockers are those beta blockers which inhibit the beta 1 and beta 2 adrenoceptors. So the name of the non-selective beta blockers are propanolol, pindolol, propanolol, pindolol, nadolol, sotalol. These are the non-selective beta blockers, and the selective beta blockers are etinolol, acebutolol, metoprolol, bisoprolol, betaxolol. These are the selective beta blockers. There is another classification of beta blockers according to their partial agonistic activity, and these drugs which have partial agonistic activity has intrinsic sympathomimetic effect. So these drugs are not used as in hypertension control, or not used in controlling hypertension, or not used in mild hypertension. These partial agonistic beta blocker properties of drug is pindolol, acebutolol, and penbutolol. These are the drugs which have partial agonistic activity, which helps the beta adrenoceptor acts on the catecholamines and increase the heart rate, blood pressure, and ultimately there may be a chance of MI over there. So these are the intrinsic sympathomimetic activity beta blockers. Another classification of beta blockers, or another beta blocking drugs which have membrane stabilizing effect, or these drugs have local anesthetic effect, and these drugs are propanolol, metoprolol, and pindolol. These are the drugs which cause the membrane stabilizing effect or local anesthetic activity. Another beta blockers which acts as in class 3 antiarrhythmic drug, and it is used in tachyarrhythmia, that is sotalol. Sotalol is the drug which is used in class 3 antiarrhythmic agent, and it helps in tachyarrhythmia. These drugs has the these beta blockers have the property to blocking the potassium channel. So this drug is sotalol. The use of beta blockers, where we can use the beta blockers. Beta blockers are used in cardiac indications. These cardiac indications are very important. That is mild hypertension, that is angina pectoris, that is supraventricular tachycardia, and we can use in initial stage of MI. Uh, the another use of beta blockers are extracardiac use. These are hyperthyroidism, these are migraine prophylaxis, these are Parkinsonian tremor, these are anxiety state, generalized anxiety disorder. These also use we can use beta blockers in glaucoma. That is timolol can be used. 2% timolol can be used in glaucoma. So these are the important indications of beta blockers. So why beta blockers are choosing in mild hypertension? Beta blockers, if we say the non-selective beta blockers are chosen in mild hypertension, that is propranolol we can give in mild hypertension. Propranolol blocks the beta 1 and beta 2 receptor both. So by blocking the beta 1 receptor in the heart and the juxtaglomerular cells in the kidney, by blocking the beta 1 receptor in the heart, it blocks the uh, heart rate. It blocks the heart rate. It reduces the force of contraction. Ultimately, it reduces the cardiac output, and ultimately it reduces the blood pressure. In case of juxtaglomerular cells of the kidney, where it inhibits the release of the renin. When renin is not secreted, the renin cannot convert the angiotensin to angiotensin 1. So that's why no angiotensin 2 is formed from the angiotensin 1 by angiotensin converting enzyme. When angiotensin 2 is not formed, the aldosterone and the increased absorption of sodium water cannot be formed. So there will be no rise of preload, and there will be no vasoconstriction. So there will be no vasoconstriction, causes vasodilatation, and decrease the total peripheral distance, and decrease the cardiac output, and decrease the blood pressure. As for we all know, the blood pressure is depends on cardiac output and total peripheral distance. So when there will be decrease of cardiac output and decrease the total peripheral distance, so blood pressure will be easily decreased. Another mechanism of propranolol, that it inhibits the beta 2 receptor in the presynaptic membrane. So inhibit the beta 2 receptor in the presynaptic membrane or in the vasomotor center, there will be no sympathetic discharge. So as far there is no sympathetic discharge, there is sympathoplasic or sympatholytic action over the heart, and the sympatholytic action of the heart, that is decrease the heart rate, decrease the force of contraction, decrease the cardiac output, and ultimately decrease the blood pressure. So that's why and this is the mechanism of action of beta blockers. So that's why we choose non-selective beta blockers in hypertension, and we can also choose the selective beta blockers in hypertension. Atenolol can be given also in hypertension. Okay. Some question may arise, why we give beta blockers in angina pectoris, and it is discussed in this video previously. Now we should discuss why we give beta blockers in hyperthyroidism. We give beta blockers in hyperthyroidism is for these beta blockers inhibit the iodide tapping, or it inhibits the organification of iodine. So that's why the hormones that is released that will become less release from the thyroid gland. One mechanism is it. The second mechanism, in case of hyperthyroidism, beta blockers causing blunting of sympathetic activity, because in case of hyperthyroidism there will be oversympathetic activity. This oversympathetic activity is inhibited by propranolol, and it is called the blunting of sympathetic activity. And when it inhibits the sympathetic discharge from the vasomotor center, there will be no there will be decreased heart rate, there will be decreased the cardiac output, and ultimately there will be decreased the blood pressure. So in hyperthyroidism there will be hypertension due to over sympathetic overactivity. So when sympathetic blunting is done by the propranolol, there will be no rise of blood pressure. And another thing is the peripheral conversion of T4 to T3, T4 to active T3 is inhibited or is blocked by using propranolol. So that's why there will be no rise of thyroid hormones in the blood, and ultimately the hyperthyroidism uh, blocked over there, and this is called the and block therapy in hyperthyroidism by using propranolol. So why you use it in hyperthyroidism, it is discussed. And now, what are the adverse effects of beta blockers? Propranolol is highly lipid soluble drug. It can easily passes the central nervous system. The central nervous adverse effect is more dangerous in beta blockers. It can cause the central nervous system depression. It can cause, by using prolonged use, there will be a beta blockers may produce sedation, central nervous system depression, and ultimately, if we use beta blocker for a prolonged period of time, it increases the suicidal tendency. In heart, it produces bradycardia, it produces hypotension. Uh, and there are another adverse effect of beta blocker. It may cause sexual dysfunction in a young patient, and also some peripheral cooling may be done by beta blockers, and decrease the peripheral the exercise intolerance may occur in case of beta blockers. These are the important adverse effect of beta blocker. Now, what are the contraindication where we should not give beta blockers? In case of heart block, we should not give beta blockers. In case of diabetes mellitus or treated with oral hypoglycemic agent, we should never give propranolol, or we should never give the beta blockers. In case of Raynaud's phenomenon, we should not give beta blockers. In case of bronchial asthma, we should not give beta blockers. So what are the situation we should not give beta blockers? One is heart block, one is diabetes mellitus treated by oral hypoglycemic agent, Raynaud's phenomenon, and bronchial asthma and COPD. We should not give beta blockers. So why we should not give diabetes mellitus, which is treated by the oral hypoglycemic agent? If we give beta blockers in diabetes mellitus, which is treated by oral hypoglycemic agent may cause hypoglycemia in diabetes mellitus. So if we give beta blockers over this type of patient, it produces more hypoglycemia, one thing, and another is it inhibits the masking of the sympathetic sign symptom of hypoglycemia. So masking of sympathetic sign symptom of hypoglycemia, patient cannot be diagnosed as hypoglycemia. So when patient cannot be diagnosed as hypoglycemia, there will be produced hypoglycemic shock, and when there is a hypoglycemic shock, it is a much more complicated thing to be treated. uh, how it occurs? We know in hypoglycemia there will be two types of feature. One is sympathetic feature and another is parasympathetic feature. In case of sympathetic feature, there will be increased heart rate, there will be sweating, there will be bounding heartbeat. So these sign symptom may be masking by giving beta blockers, because beta blockers causing inhibition of the sympathetic release from the vasomotor center. So when it inhibits the sympathetic discharge from the vasomotor center, so the sympathetic sign symptom will not be produced in this type of hypoglycemic patient. So the patient cannot be diagnosed as hypoglycemia because the features are not prominent over there. So when the features of hypoglycemia is not be prominent over there, and the patient may goes any type in any moments goes into hypoglycemic shock. So that is one thing. Another thing, beta blockers normally produce hypoglycemia in diabetes mellitus patient because it blocks the beta 2 receptor in the liver and beta 2 receptor in skeletal muscle. In beta 2 receptor, when it blocks the beta 2 receptor in the liver, it inhibits the glycogenolysis and neogluconeogenesis. So there will be no production of glucose present in the blood. So there is a more chance of hypoglycemia. These are the things that beta blockers causing more hypoglycemia in diabetes mellitus patient or diabetes mellitus treated with oral hypoglycemic agent. In case of Raynaud's phenomenon, there will be peripheral cooling or peripheral cyanosis is present in Raynaud's phenomenon. So when we give beta blockers, it causes peripheral cooling. So peripheral cooling, it increases the peripheral cyanosis more also. So in Raynaud's phenomenon, beta blockers cannot be given. Okay. In case of heart block, there will be bradycardia. So when we give beta blockers, it produces more bradycardia and heart block may be complicated more and patient may die. So we should not give beta blockers in case of heart block, in case of bronchial asthma or COPD, in case of Raynaud's phenomenon, and in case of diabetes mellitus when treated with oral hypoglycemic agent. So that's all from the beta blockers. Next we will discuss about ACE inhibitors and angiotensin 2 receptor blockers. Thank you.